The average person at a doctor's appointment gets interrupted after 17 seconds? We tend to talk at people a lot instead of listening. But when I was able to listen, that was what made the biggest difference, I think, and to be able to accept people's fears, to let them be wherever they were, I think is really the biggest gift we can give someone who's struggling with a serious illness or at the end of their life.
Welcome to Radical Nurse Talk, a podcast that explores nurses' communication in serious situations and illness as a radical act of care. I'm your host, Patricia Strachan. Nurses can also be patients, and the view from the other side often gives nurses lots to think about. This was the case for Theresa Brown. In our conversation today, Theresa reflects on stories she lived as a nurse and a patient. She talks about the tensions in these from both perspectives and their influence for developing relationships with patients who are desperately trying to survive. Theresa lives in Pittsburgh, and she's had a remarkable journey as an academic, oncology and hospice nurse, patient, author, and international speaker. Her book, The Shift, One Nurse, 12 Hours, 4 Patients' Lives, was a New York Times Bestseller. In April 2022, she released her third book, Healing, When a Nurse Becomes a Patient, that powerfully and candidly lays bare her own journey following a breast cancer diagnosis. Her insights and experiences offer much to help us understand, value, and learn from the critical importance of nurses' talk with patients and families. Today, we're going to explore aspects of those conversations, words and phrases that might be understood as difficult or hard, and sometimes what are the most mundane situations. This from Theresa's perspective as an oncology nurse and patient. Welcome, Theresa. I'm thrilled to have you here today.
It's my pleasure to be here. Thank you.
I'm wondering to start with if you can briefly let us know about your background as a nurse.
Yeah, so I have a PhD in English. I thought I was going to be an English professor when I grow up, and taught for 3 years at Tufts University, then had kids and felt like I wanted something different. And it was really being pregnant with twins and then having baby twins. What I always say is I fell in love with the mess of life, which when I say that to nurses, they all nod their heads. Non-nurses look a little bit perplexed, but like they're interested. So the reality of having these 2 tiny babies and then our son who was a toddler and, laundry and diapers, but also love and joy and laughter. And, what job is like that? And I have a friend who's a nurse who was visiting when the girls were about a year and a half. And I said, I just thought the midwives I had the coolest job in the world. And she looked at me and she said, Theresa, you could do that job. And it had never crossed my mind that I could become a nurse. And then I did some research and found out, wow, I could become a nurse, and learned about accelerated programs where people don't know if you have a college degree in anything or a PhD, you can get the science prerequisites that you need and then do a nursing program they tend to be a year to a year and another semester. So that's what I did and loved it. I mean, nursing school is hard. I can't say I really love nursing school, but I loved learning about being a nurse, and then began working in oncology with leukemia patients and bone marrow transplant patients. Then went to outpatient oncology, home hospice, and along with that became someone who writes about nursing and healthcare.
I'm wondering what you learned about how to talk to patients who are living with these serious diagnoses, leukemia, etc., or undergoing very high-risk treatments. Do you recall any education that you had or thinking about what to say?
Lots of thinking about it. This is a situation where being older made a huge difference because I could bring more life experience to the table. But also my PhD in English meant I had a keen awareness of stories, the power of stories, also what gets told and what doesn't get told. It made me a really good listener to people's stories. And also it made me a listener. And I think that's something that doesn't get talked about enough in healthcare. You know, the average person at a doctor's appointment gets interrupted after 17 seconds. We tend to talk at people a lot instead of listening. And I have definitely done that too, like going through discharge instructions, which, you know, have been delayed by 4 hours and people just want to get out of the hospital. And my mind is on, let me get through this task, have them sign the form so they can leave. I have talked at people, but when I was able to listen, that was what made the biggest difference, I think, and to be able to accept people's fears, to let them be wherever they were, I think is really the biggest gift we can give someone who's struggling with a serious illness or at the end of their life. And then if there were specific questions they had, you know, the doctor told me this morning, and I don't understand how that chemo works. And okay, well, I can try to answer that, but, you know, then we can call the doctor and have the doctor come back. Sometimes someone really wants to talk to a religious figure. They want a priest to come in or a rabbi. Okay, I can make that happen. But the essence of it is meeting that person where they are. What do you want? You know, once we had a long-term patient who just really wanted to see her dog. And I did the work to set it up so her little teeny tiny dog could come in and she could spend an hour with her dog.
Yeah. So I think in my experience anyway, having the time to be able to actually listen is something that nurses really struggle with and is often something that's not understood widely as important as perhaps some of the tasks. I don't know if you found that to be true. So how do you have time to listen to stories?
Wow, what a great question, because as anyone who's been in the hospital knows, you're always carrying a phone and the phone will interrupt you at any time. Occasionally, when it was really important, I would ask someone if they could take my phone for me. But you're right, I had to have time to do that. And a colleague who was willing to do that. It can be very, very frustrating to know that someone needs to have a conversation and I'm there for them to lean on me, but I just don't have time to do that for them. That's hard and it's getting harder. And I think the public doesn't understand all these discussions about staffing. You know, there are so many things you can't do as a nurse when you're overworked. There are tasks that will not get done. There are crucial signals to how people are doing that will not get seen. There are also emotional needs that will absolutely not get met because the nurse does not have time. You know, that is hard. And there's a cumulative effect of all that missed stuff. But the importance of meeting those emotional needs and wanting to be there for patients and not being able to be cannot be understated. That really matters. So to nurses listening, you know, if something's really important, are you able to give someone else your phone? Can you ask your manager if you can carve out 15 minutes to be with someone? Sometimes you just get really lucky and you go in to talk to someone and your phone doesn't ring. Hallelujah.
Yeah. And perhaps this is something that we should be elevating beyond your charge nurse or your supervisor and having administration and people who make decisions about the conditions of nurses' work, that they understand that. I'm wondering, as a patient later, living with a serious illness, did you ever think about what we were just talking about? Were nurses available to you? Were there times you wanted to share something or ask something and felt you could or couldn't?
There were so many times I wanted to ask something and felt like I couldn't. And that's really what motivated me to write Healing, because being on the other side, I could not believe how lacking in compassion the healthcare I received was. It was truly shocking to me and upsetting. It made me look back and see moments where I knew it wasn't really meeting people's needs, but I was so pressed by the system, I wasn't able to. And I saw those moments in all their emotional complexity for the patient. And that's part of what the book is about. But also just, after getting my initial diagnosis, after a follow-up mammogram, I was told, you will not leave today without a biopsy scheduled. Went to schedule the biopsy, sitting there, obviously been crying. I was probably still crying, sitting there. Finally, someone comes by and says, oh, she leaves at 3. You just missed her. And this is not a terrible thing to say necessarily, right? But in that moment, I wanted to hurt that person. It felt like such a diminishment of what I was going through and what I had been promised and what I felt like I needed to feel like I'm not just alone with this most likely cancer diagnosis. That just happened over and over and over again. I mean, even at one point this was afterwards, they were trying a certain kind of treatment because tamoxifen, the usual drug you get, wasn't really working for me, and I'm waiting in the treatment center. And the nurse comes out and says, well, the doctor hasn't signed this order. Like, why would you tell a patient that? And here I am, I'm a nurse. I just felt like, first of all, I don't need to know that. And second of all, you're in a hospital. Go find a doctor to sign the order. I mean, because that's the kind of nurse I was. I'd be like, this order needs to be signed. So who is going to sign this order? To me, though, it speaks not to that this was a bad nurse, because I don't think she was, but to how much pressure there is for all the paperwork to be in place and everything to be checked and the I's to be dotted and the T's to be crossed. And it just bleeds over into everything. So instead of me being able to show up and, oh, hey, great, here's what we're going to give you. Do you have questions? Let's educate you. It becomes this whole ridiculousness about the paperwork's not signed and, oh, what about this? And what about that? And they're sort of conferring about it in front of me. And it's horrible. No one should do that in front of a patient. I just was appalled. That's a strong word, but about how little feeling there was for where I was and what I was going through.
So a focus on procedures, task, and you didn't feel it was about you, even though it was about you. It wasn't meeting what you needed at that time.
Right. And certainly that information can be presented, but it always needs to be presented with empathy for the patient. Hey, we're really sorry. Your procedure's gotten postponed. Hey, apologies. I don't know why it's taking them 3 hours to read your mammogram, but it doesn't mean that you've had a cancer recurrence, which is what happened to me last time I had a mammogram. Instead, I don't know if people feel like they shouldn't say that they're sorry. They're not good at explaining. They're so afraid of someone blowing up at them that they just don't want to talk about it.
Yeah.
But it would be really easy to diffuse a lot of bad feeling by just coming to people and saying, hey, I see you, you're waiting, and waiting is hard, and here's what's happening. And when I was writing Healing and looked into research on compassion in healthcare, there's a lot of evidence that very small interventions like what I just mentioned can make a huge difference. And, you're giving someone the same message. Well, your mammogram, they'll get to it when they get to it. In the same amount of time, you could say, hey, I know waiting's hard. This doesn't mean that it's bad news. It's what do you say in that moment that can help someone feel better instead of making them feel like they're on the healthcare assembly line. And all that really matters is, did you give your copay? Which I know from working with nurses and doctors, definitely the human matters more than the copay. But as a patient, it's easy to just feel like it's about, did you pay your money? Are the boxes checked? Okay, next.
So that's something right now in our system in Canada that we are wrestling with. We don't have those copay conversations, and we're hoping not to. But we do have lots of checklists. I remember in your book, you using a phrase about feeling one of many. I think that's something. So maybe that's like the assembly line.
Yes.
Yeah. So although this podcast and our focus is really around hard conversations, this is really around situations that are hard for the patient that don't seem to be about difficult conversations. And yet the conversation becomes difficult because you feel ignored or invisible as a person.
Right. They're not difficult conversations, but they're not about difficult subjects, but they become difficult conversations. And it could be partly that the difficult subject is kind of there on the edges. I'm a cancer patient waiting for the results of a mammogram, which puts so much more stress on the waiting than if I hadn't had a cancer diagnosis. That's actually really helpful to think about what's not getting talked about, what's at the edges there of the procedure, the test. What is this person afraid of? Even if they look calm and like they aren't afraid, or even if they look really angry, or what's going on for them. I'm not saying it's easy to do that, but the point is really, it doesn't have to be that hard and that time consuming to see people in the moment and just help them a little bit. I said, nothing can make a cancer diagnosis better, but what I wanted was for it to be easier. I just wanted the whole process to be easier than it was. And I hear from people who go places where it is easier. The care is coordinated, things are done in a timely way. You don't have to make 10 phone calls to find a surgeon so we do not have to reinvent this wheel. That car is out there driving, but just not that many places.
So I'm thinking about your comment about anger or frustration. And one of the quotes, I think, from your book, or maybe it was a quote about your book, is talking about confronting the most critical, terrified, and angry patient that you've ever encountered, which you said was you.
Yes.
Is that true?
Yes.
And so how is it? So obviously that anger is coming from somewhere. And in terms of nurses talk, what do we do with that? And maybe some of the edges that you were just talking about that people fear to tread in might be about that anger.
Well, for me, it was a feeling of not being seen as a full human being who was scared, who has children who I feel like still needed their mom. And even though they were in college, but, they weren't fully launched. And also that anger came from me, the nurse, having worked with really sick oncology and hospice patients and feeling like, this should be a slam dunk. Like I had the most common kind of breast cancer, the progression from mammogram to biopsy to surgery. I had genetic testing in there, so that, which was all negative, but that's a complicating factor. But, this is not figuring out a treatment plan for some mysterious glioblastoma or some really rare cancer. Yet it was like they were reinventing the wheel every single time. So that was a lot of my anger too, is feeling like, why doesn't this just work? Why doesn't it work better?
Mm-hmm. Are you able to recall what you would have called a hard conversation or a difficult conversation to have when you were an oncology nurse?
Oh, yeah. I remember this actually was one of the times I asked someone to hold my phone. It was a long-term patient who things were not going well for him, and his wife just wanted to talk. And I actually had time it must not have been a busy day, because I knew she wasn't eating, and I actually had time to go buy her something to eat. And then we sat in the patient lounge and just talked for half an hour, and all her fears about he wanted to keep getting whatever treatment was available, because people listening should know, doctors are often always willing to offer something, and they'll say, well, it might do some good. And they don't talk about the negative effects of that and weighing risk benefit. Like a lot of oncologists are just not good at that. People should know that. But just sitting with her and listening to her, understanding that her husband wanted more treatment, and her saying, how am I supposed to even get him in and out of the house? Like he can barely walk. She was very petite. He was a very tall man. And taking in the challenges that she was facing, then later talking with him, and he was just so confused about what was possible, what wasn't possible, what might actually help him. Those were very difficult. And what I tried to bring to that was a sense of humility, that this is not my decision. There is no obvious, this is the right answer, except that I think the physician should have been more forthcoming with him about risks and benefits. But what is going to work for these two people? Really challenging. And I feel like I did my best that day to be an empathic sounding board. Did I help them get closer to their decision? I hope so. I don't know for sure, because it was just a very, very difficult situation, because just his disease was making it really, really hard for him to even stand up, couldn't walk, very tough.
So it sounds to me like you're saying the listening was hard, that it wasn't necessarily your hard talk. And then what do you do with that as a nurse? How do you respond?
Yes. I think that's why we have such a temptation in healthcare to rush in, to fill that space, to fill that silence. I mean, I'm part of a program here in Pittsburgh where I work with people who get a fellowship to talk about death and dying. And I end up giving a talk for them once every single time. And what I really try to get across is this message of patient autonomy and respecting what patients want, which takes time, which again, as we've discussed, a lot of doctors and nurses don't have, but also takes a lot of patience. And patience can be hard. PATIENCE, not hospital patients.
Right.
Patients can be hard. And as humans, we don't like uncertainty. We don't like being in situations where we can't say, this is the best choice. This is second best. This is the third, especially if it's what we're offering people, right? All of that is really, really difficult as a clinician to meet someone halfway. And I'm remembering now another time when I was in home hospice visiting a hospital patient, because you can be on hospice in the US and be in the hospital if there's a need for that. It's a, complicated bureaucratic thing, but it is possible. And patients shouldn't have to worry about the bureaucratic part. But husband whose wife had a feeding tube, she was non-responsive, and she'd always said she didn't want a feeding tube. And I just sat there and talked with him about, what do you think? And just let him, and I had the time to let him just talk that through. And after about half an hour, he said, so I should have that feeding tube pulled. And I said, well, that would be my recommendation based on everything you've told me, putting it in his terms, his values, her values. But we're getting back to one of your initial questions. We're not educated that way, right? At least not in the U.S.
I think that's a global, global issue. And that's why we see a lot of programs that have popped up for nurses and physicians and other health professionals post-licensure, because once people are out there, they recognize it. And all of the things you've been talking about, the frustrations working within the system, has influenced some of the program development that's happened. I wonder if we can pick up on a couple of things. So one is, to me, all of the things that you've just been describing reflect to me how complex the relational work is. You've been giving a lot of examples about how complex nurses' relational work, communication with patients and family, really is. And in the moment, dynamic, unpredictable, you're not sure what's happening, and focused on how demanding it is for you to be patient. And then the work in helping patients and families interpret what is happening. I wonder if we can switch over to life as a patient for you and look at nurses' communication and relational work from that perspective. You've said cancer has its own language, and I'm wondering, you were very familiar with it really as a nurse, and how did that shift for you, or what new insights did you have as a patient?
The hard thing that I brought to the table was I'd worked as a nurse with people with very serious, aggressive cancers that required arduous treatment, extended hospital stays. And so I had a distorted sense of what treatment would be. And it took me a while to figure that out. Like, this is stage 1 breast cancer with the best kind of possible tumor markers. This is not acute leukemia. That didn't help me. But the thing that did help was knowing really the language of healthcare and how to get the system to work for me, or at least try to get it to work for me. The one cancer language aspect I did not get as a nurse is the emotional aspect and how it really takes over your brain. At least for me, I was afraid. And the way that manifested itself was I just became very forgetful. And in our family, we joke about me having this memory that's like a steel trap. Suddenly I was just forgetting all kinds of things, important things, trivial things. That's the way I managed it, if managing is the right word. And, at times being tearful and sad and scared. And I had not understood how omnipresent those feelings are for patients. It's really a challenge because you can't come to work feeling 100% empathic for everyone, their fear of death every single time. You will burn out in a month, right? But to have an awareness of that seems really, really important. And as I say in healing, we had language as nurses that tried to kind of eliminate that. Like, you lost your hair, but we're saving your life.
Yeah.
You have an IV line that's sticking out of your chest, but we're saving your life. And as a patient, I realized, okay, yeah, you're saving my life, but also I'm scared and I'm having surgery and now I'm having radiation treatments. And then for me, the hardest part of treatment was tamoxifen, the after treatment. And after 3.5 years, like half the women on this drug, I felt like the fact that this is maybe going to prevent a recurrence is not enough anymore. I'm not staying on this drug. So the humanity of each individual patient, that is what got left out of the relational picture.
So what is it that you think happens that we offer the bright side of things?
It's hard to bear the weight of all that suffering. Also, though, treating acute leukemia or a lot of cancers there's a sort of built-in ethical dilemma, right? Because we're giving people treatments that make them sick.
Mm-hmm.
And that for some people, they'll have lifelong side effects.
Mm-hmm.
And yet we are saving their life. Like, both things are true. But also, as practitioners, that complexity doesn't get talked about. And I think if it would make it easier. The relational between nurses and doctors. I hate to use the word siloed because it's so overused, but I think it's useful here because, not only are we not always good at talking to each other, we're certainly not good at talking across professions about feeling responsible, having an ethical dilemma. It's sort of, we're not talking about that. We're talking about treatment. It's this kind of mantra that we all absorb. Like, we could talk about both,
Okay.
both are possible. We could really talk about both, but that is not always what ends up happening.
No, so maybe it's a case of what you were pointing out before, and that is acknowledging that that's happening and setting out there that it seems, so different from the fact it's so opposite, but you're experiencing both things, that you're hopeful that your life is being saved, and then you have to experience this. I recall this with a patient who had severe neuropathy following chemotherapy, and describing that to the nurse and the physician, but then them saying, yes, that happens. And it's true. It does. It says it in the side effects, but then to live that and then to live with that forever is very hard.
Yes. And I've been there. I've heard those conversations, and I'm embarrassed to say, didn't always think about what are we going to do to help this person.
Yeah.
And that's the other thing. It's just kind of like the sense of clinician responsibility ends with the cancer. It's like, well, we cured your cancer. Like, yeah, you can't feel your feet, and so you can't walk very well, but you don't have cancer, I mean, it's like I'm laughing because on one level, I get it, but it's also absurd.
Yes. Acknowledging the absurdity is what you can do. I think that's what I'm hearing you say. You can't really change it. That's how it is. But pretending that one doesn't exist and the other is not so helpful.
Right. And again, in that moment, you can say, yeah, that happens to some people, or you can say, I'm really sorry. And, we don't have a good way to help you with that. I wish that we did. Would physical therapy make a difference? Would strength training, just in terms of helping with balance, even when people can't feel their feet? I don't know that research. I think patients feel hopeless. And on the clinician side, it's, well, that's not my responsibility. My responsibility's over. It's not even about really taking ownership of the side effects. It's again about seeing this whole person. If someone, say they're a nurse and they can't walk well after getting chemo, well, then you can't work as a bedside nurse. You can't do that job. What if you lose feeling in your fingers and you're, someone who, I don't know, fixes telephone panels or does something that involves really fine motor work, and now you can't do that job anymore. These are not trivial issues. And it's interesting, even since leaving clinical work, becoming a patient myself, I've been able to listen to women talk more about losing their hair and how it's really traumatic for some women. Some women don't care, but for some women, it's huge. And I think I just could not have taken that in. It doesn't take that much as a clinician to see that, to understand that, to say, yeah, hey, that sucks.
You've identified some words and things that struck you differently when you were a patient. Anything else that sticks out to you, sort of metaphors or terms that got used or that you use that you think about differently now?
Two things, and I wrote about this, and Susan Sontag in her book Illness as Metaphor really talked about all the battle metaphors we use for cancer and how destructive they are. And I feel that very strongly, but will also confess, I would sometimes hear that in my head. A patient who died, I would say, oh, he fought the good fight. And then I would think, why are you saying that? And the thing is, there's no other disease we talk about that way. Why does cancer and cancer patients have to bear this burden of fighting? Like, no one says, you're not fighting your ALS, you're not fighting your heart disease. So there's so much to unpack there. And then the other label that I found difficult, even though I know people meant it with such good intentions, and I was always very kind about it, but was the word journey. You're on your cancer journey. I do feel like I'm on a healing journey, and I feel like I will be on that for the rest of my life. Not just cancer, but just that's human. That's being human. But whenever people said in your cancer journey, I always pictured me in an airplane seat with like my tumor next to me, like one of those M&Ms with the hands, and except it was a tumor, so it was gross. And like nobody wants to go on a journey with cancer. But I knew people meant it well. They were coming from a good place, but again, no other illness. You don't go on a journey with any other illness. That felt like such a burden, but I have to fight, but then I also have to be zen on my journey, and very confusing set of conflicting expectations. And so I just like the words diagnosis, treatment, and let's not burden cancer with all these metaphors that are hard.
Yeah, they're hard, I guess, because there's expectations built into them around how you should be feeling or acting. Is that correct?
Yes. I guess throw one more thing out, the pink for breast cancer awareness and Pinktober. And so I was diagnosed at the start of September. And so just that October was horrible for me, that everywhere I went, there was just pink everywhere. And so everywhere I went, it's like, you have breast cancer, you have breast cancer, you have breast cancer, which was unpleasant, to say the least. But again, as I talk about in the book, the whole idea of pink and the feminizing of cancer, and saying that like, what's really upsetting about breast cancer is that you might lose your breasts. And like, no, I think it's really upsetting that you might die. I did not lose my breasts. I think losing your breasts is also hard, but it's not the same thing as losing your life, and how this whole like losing your femininity gets oddly wrapped into it. And I found that very hard, and as do a lot of women. What's interesting to me is I have not met a single woman who likes the pink. And it may be that they know how I feel, and so they don't tell me. But I have met no woman who likes it. And in fact, the women who talk about it really, really dislike it as much as I do. I'm not an outlier. That just seems like such a shame that the Susan B. Komen Foundation, who started the whole pink, couldn't rebrand in some way. And we could not have Pinktober, and, that fundraising could not be connected with the idea that by having breast cancer, you're sort of losing something essential about being a woman, which...
Yeah, that's interesting. It's on bread wrappers, the pink.
Yes.
Yes. Yeah, no, it's
NFL players wearing pink socks.
Yeah. So is the message that we just need to be thinking, maybe more thoughtful around what we're buying into, or messages that we assume are being understood in certain ways.
And I think cancer is scary. It's scary if you have it. It's scary to hear about it if you don't have it. And that's my theory about why we get all this language, because it's scarier than other diseases that actually, well, I guess only heart disease kills more people. But I brought up ALS because ALS is such a terrible, terrible illness. Yes. But cancer is uniquely frightening. It would help patients if we could unburden it from all these expectations. Even Siddhartha Mukherjee's book, Emperor of All Maladies, I read it when I was an oncology nurse. This is a great book. Of course it won the Pulitzer. Then when I was a patient, I felt like, I don't want someone to say I'm the emperor of all maladies. That makes me feel terrible. So, it gives the disease so much power and lets the disease shape our lives rather than letting us just live our lives with the disease, which is hard enough.
Yes. I wanted to return just briefly to the point you made earlier about being forgetful. Wanted to just point out that is something that people talk about under great stress. So that cancer, having the diagnosis, is stressful. But carrying stress, and certainly catastrophic stress, which it may feel like that at the beginning or at certain points, does create brain freeze.
Yes.
that freeze. And so that's something I've noticed that we don't appreciate. And I don't think I did as much, in clinical practice, that all the things that I was saying, I'm assuming are being taken in and remembered, but they may not be, because the physiology of the other person is interfering with that. So I think your point around what it is that patients feel like is important, because it does change what they hear, and if they hear, and if they remember things that we do think are important to share.
That's a great point. And listening to you, I realized that was part of my anger too, was a frustration with myself. Like, I'm not functioning at the level I'm used to, and the system is making everything harder for me. That was also part of my anger. I need things to be easy for me. I need people to help me. And instead, I feel like I'm back being a floor nurse, pushing a huge rock up a hill, hoping I don't lose hold of it. Yeah, that's just a really good point to keep in mind. And I've actually had that come up at meetings, workshops I've gone to, and I've said, when people are sick, they're not paying attention as well. They're not going to remember things as well. And clinicians nodding like, oh yeah. I mean, and it's not that these are unfeeling people. I think we just forget.
Yeah, we do. What is it that you do or have done to bring yourself into a place where you can listen better? Is there anything that helps you do that?
Try to exercise a lot. I think I am of a listening bent. I think I like listening. I mean, I enjoy doing podcasts and being interviewed, but the truth is probably it would feel more natural to me to just sit and ask you questions and really listen to what you were saying. So I think in some ways it might come a little bit naturally to me. And I'm, a little bit introverted and all that stuff. But when it's for work, I try to keep a separation between who I am and who they are and give them back their autonomy, have respect for their individuality, or if it's a family, or what that family needs. And that to me seems key. It really bothers me when I hear that a doctor will say, well, if you were my dad, this is what I recommend. If you were my daughter, that patient is not your dad. They're not your daughter. And I know what the doctor is trying to say, but it's this sort of ownership of people that we kind of fall into in healthcare, and it puts up a barrier between us and who they are. So I try to see each person as an individual, but that's also part of why I went into home care, into home hospice, because I felt like I was losing that in the hospital. And I wanted to recover that sense of patients are people, not just sort of helpless figures wearing ugly gowns, who, we never let sleep.
Right. And I think just what you were saying there reminds us the power that we have, even in our conversations that seem so simple. So saying, this is what I do, or I feel the same way, or whatever, that also carries power around patients' decisions.
That's a great word to bring in. Yeah.
Well, so here's another great word. I read in your healing newsletter a notation about compassion is the radicalism of our time.
Yes.
And I thought that was so beautiful, considering this is radical nurse talk and recognizing that nursing communication is a radical act of care. So it seems like a very good
yes
note to finish on, that compassion is the radicalism of our time. Something to think about.
I taught a class that Carlo here in Pittsburgh this past spring called Healing Through Writing and Storytelling. And at one point, I had the students read some short stories, because we read fiction, nonfiction. They wrote about, we talked about, they were psychology students, actually, talking about the power of stories and healing. And the student said, this story reminds me of our world right now, which is that nobody really cares about anybody else. And they all felt that way, these students in their 20s. And I thought it made me so sad, but also speaks to that idea of compassion as the radicalism of our time so profoundly. And here in the US, COVID, it was like a national wound, that still has not healed. Yeah, if compassion is empathy in action, which is how some people define it, it is radical. And I hate to do something like encourage everyone, try to do one compassionate act a day, but maybe that's not a bad idea. Maybe that's not a bad life goal.
That sounds like a wonderful note to leave our conversation today. I think I could have this conversation for hours with you, but that's a wonderful challenge or thought for us all to take away. Thank you so much for this rich conversation, Theresa. How can people get in touch with you or access your ideas or your books or your website?
So my website is theresabrown.com. It's Theresa with an H. And there's a contact, you can reach me there. I'm still on Twitter at Theresa Brown, and I'm on Instagram at Theresa Brown RN 2021. I'm also on Facebook. I'm a Theresa Brown on Facebook. But yeah, if you want to email me, find me through my website. Sometimes I'm slow getting back to emails, but I definitely read them. I enjoy them, and I do eventually respond to them, sometimes quickly, sometimes not. So
thank you.
Thanks for listening. You can reach me or information about this episode on our website, www.radicalnursetalk.com. The editor of this podcast is Jeremy Ramos Foley. Social media by Amy Strachan. If you'd like to support the show, please rate, review, and subscribe. Join me next week for more Radical Nurse Talk. In the meantime, have a radical conversation in your practice. It can change lives.